Hello, I'm in Austin, Texas right now. My name is Liz Kromrei, and I'm with our child welfare system. And I'm one of those folks that's been around a bit. I'm closing in on 40 years of working with abused and neglected children. And I have lost count over those years of how many times I have either thought or said out loud, I can't believe how different it is from when I started. But, making the shift, when you think about 40 years ago, we were in payphones without computers. And now everyone has a cell phone. Can't imagine doing our work without computers. And quite honestly, can't imagine my work now without some of it being on a Zoom or a Teams or a GoToMeeting or some other virtual setting. So, it has changed. And I really do believe that expanding beyond the concept of telehealth to just virtual interactions with families in our child welfare system, whether it's in courts or service provision, that I think the hybrid environment is here for us to stay. Regardless of that, over the years, the child welfare has remained a challenge. Some things aren't changing. Our families still don't have what they need. And child welfare in our state is often viewed as the safety net. We are catching the children where all other systems have failed, and that gives us ongoing challenges. So I'm going to talk some about what we're experiencing in Texas. And did it change? Yeah, it changed. Okay, well, just first to give you a little snapshot about us. We are a state administered child welfare system. You see our map up there with some regions. We have 254 counties, and they're grouped in 11 regions. But some of these regions have a couple of divisions in them. We call them catchment areas as we transition to community-based care. And on any given day, we've got 30,000 children in our legal custody. And those children, if we looked at them like last night, about 88% of those children are in a home setting, almost equally split between a foster home and a kinship home, slightly more in our foster homes. We have about 6% in residential treatment centers, 2% in a shelter. So they are kind of spread throughout. Also want to talk about just the context of population. The Administration for Children and Families has posted some data about child population through 2020. So not 21, but 2020. And the US population has decreased by about 1 million. Our state is continuing to increase. We didn't see all of those 1 million children be added to our population. We increased a little over 100,000, but we are growing. The child welfare system nationally has gone from 3.31 children per 1,000 children. It has gone down. Texas has always talked about it being we've always referred to ourselves as a low removal state. But we also have gone down. So our removal rate was 2.62 per 1,000 when the country was at 3.31, and we've gone down to 2.22. A few states are ahead of us. I think New York is way ahead of us, but that's the direction that we're continuing to move in. So when we talk about our challenging times, it is difficult for us in Texas. We are experiencing many things that other states are. I mean, we have weathered hurricanes, we've weathered localized events, and that has enabled us as a state administered child welfare system to shift our staff to help each other out from one part of the state to the other. And I think this is the first time where it impacted all 254 counties. It's like Seth described, and I'm sure other states had. We began in March with everything locking down. We all hunkered down in our homes, did things virtually. We went for many months without contact, and when we did have contact, we looked like space people, coming in and covered in PPEs and the sound breathing through the ventilator deal. It was difficult, and I don't know about you guys. I went from one Zoom meeting to another until the end of the day. It was just like I could not sit before a computer screen ever again. We worried about our families. We went to great lengths to make sure that families had visitation via virtual means, even if it meant us standing outside of a house, handing a phone in to do FaceTimes. We did that. And we have the pandemic impact is still widespread. We've shifted to a much more hybrid time, and I'll talk a little bit more about that. But the pandemic impact hit everyone. I will say it impacted our service providers, and not just the behavioral health or healthcare providers, but our caregiver system, the people who had our children in their homes and in their facilities. And it was very amazing to us to see when everyone kind of clamped down that our families hunkered down with the children in their care. We did not have people drop off children because they were COVID positive. We learned to distinguish between isolation and quarantine, and we really saw people try and adjust. It continues to impact our service providers. The cost is up because the ratios are impacted. We had people taking care of our children who had children going to school, and when they were staying home in school, that was a whole different kind of care. Children really had a challenging time adjusting to that. We've seen during this last 18 months some adjustments in our state law. In Texas, we have a legislative session the spring of odd numbered years. So our spring 2021 was the first time that we had a session. It was really very different. We're used to families and advocates and stakeholders coming and talking in hearings to legislators, and that was really different. We are also today in the midst of a third special session as we try and cope with finishing, as our legislators try and cope with finishing the work and changing the laws that needed to be dealt with. So we have been almost continuously in session, which is real different for us. Capacity issues are a challenge for us, and you've probably read about Texas in news clips about the child welfare system. We have always had several children who are not in placement and supervised by our staff in an office setting. For example, if a child is removed in South Texas and being placed with a relative in the Panhandle, and removals in the evening, we don't drive all night long. We wait till the morning or wait till a relative arrives. So we've always had children in the office that or a different setting, a hotel setting, that are supervised by our staff. But we have in the last year really experienced the consequences of the impact of, starting with COVID, of challenges to our capacity. We've had a fragile behavioral health continuum for children in our state from one end to the other, and adding a COVID pandemic on top of it and the impacts to cost and programs and mental health and families and just everything, it has been frayed quite a bit. So our capacity has meant that we've had as many as 200 children who do not have a single placement in Texas or outside of Texas, and we've had them in the office and in hotels and trying to cope with meeting their needs. That's been a huge challenge for us. And a lot of this has impacted our staff. Our staff have family members in their house who are fragile. They themselves have health issues. Some of them have made decisions about children in their home and school options that they are not returning to our workforce even when we came back. So the impact of the pandemic has been widespread, and that is the challenging time in which we are doing our work. So I want to take just a kind of a sidestep and talk about our use of the Child and Adolescent Needs and Strengths Assessment tool and why we did it. We are in use of it statewide, and that all happened before any pandemic. I've listed the bullets here. We were looking for the recognition that all kinds of assessments happen for our children entering our conservatorship, but we needed a consistent element throughout so that we could compare the needs and things that we were assessing to be issues, that we could compare them across the state. We needed to use and be more effective in our service planning and get away from the big three, which is where we were. So many of our service plans had parenting classes, psychological evaluation, individual therapy, and recognition that that was not needed for all children. We needed it to be trauma-informed, developmentally appropriate. We needed it to be efficient, and as we adjust to community-based care, we needed it to be something statewide that was comparable. And we had a managed healthcare system for children in our conservatorship, and we needed to use that. And it needed to be statewide the same. So that's why we went to CANS. We implemented it. We started in 2016. I'm really getting to telehealth, I promise, but I just want to make sure that you understand our context. It is one of 3 tools used in the first 30 days for assessing children. So the assessment is done within the first 30 days of entry, usually when it's timely. There are different levels of frequency. Just as an example, if they have higher needs, the CANS assessment is done every 90 days. We are using it as needed, but the consistency statewide for all children, regardless of their needs, as soon as they hit the age of 3, is that initial assessment. Our caseworkers are not the CANS assessors. Our external managed care system is the CANS assessor. And by policy, the actionable items, the 2s and 3s, are to be used in our service planning process. So that's our context. And one bullet I didn't put on there, it is available in a health passport that we have that is accessible to all of the behavioral health and medical stakeholders and the medical consenters for children and our casework staff for each child. So here comes the pandemic, and what happened? Right before March, in the late 2019 and early 2020, we were pushing the use of CANS with pilots. We were in the midst, when the pandemic really hit, of our 3rd pilot. I will say our 3rd lackluster telehealth pilot. And basically, we as a state and our managed care organization that consisted of the CANS assessors, we were pushing telehealth, but we couldn't get any takers. They really didn't want to do that. The rationale for us, since the pandemic hadn't hit yet, was that we had some areas where we had either no CANS assessors or very limited CANS assessors. It was difficult to get the CANS assessment done and done timely. We weren't sure that children under the age of 10 could really be verbal enough to have it be effective. We had a lot of unknowns. And so we were in the midst of our third pilot. Then came the pandemic. And what we did with the three tools that were required in the first 30 days, when the pandemic hit, we sustained one of them, which is a 3-day health screening. And we did that because we thought children new to care needed to be seen by a doctor, especially in a pandemic. So as long as we could get them seen by the doctor, we continued with that. Our EPSDT stuff, we stopped. CANS, we stopped. And then as the pandemic was, we all went home thinking it was going to be a few weeks. And as it became more protracted, we relied on our telehealth pilot for CANS, and we expanded it. And you can see the blue being face-to-face visits, the gray being telehealth CANS assessments. We really almost immediately in the pandemic hit the option of telehealth being used. It was so successful that we asked our Medicaid, because our managed care program is a Medicaid plan, we asked our Medicaid agency to give permission for that CANS assessment to be a permanent option. And that was granted. This slide's a little bit hard to see, but it is month by month. The one that's farthest to the left is January. So we had our two pre-pandemic telehealth pilots. One was in the fall. We expanded a second one into January and February, and you can see our no takers. The blue lines are face-to-face. The gray is telehealth. March is when our pandemic hit, and then all the way to the very end, you never see the blue bar being taller than the gray bar. It comes close kind of in the summer, which is when Seth was showing the march of the pandemic across the 18-month period. Before, when things settled down, we had the emergency use authorization vaccines, and people began to be more comfortable. We came close, but even then it was not over our face-to-face options. One of the things that we found after using telehealth for CANS over time is that not only did it help with pandemic-related issues, but we had some unintended and positive impacts, so that in many areas it became the first choice. For those areas that we were trying to really help, our more rural areas or areas where we were having coverage issues, it took care of that. It addressed those coverage gaps. But the first bullet, what I have there is it addressed availability and local limitations. We found that there were people that were not enthusiastic about the CANS because, quite honestly, they had a CANS assessor that may not have been using it as it should have been used, or using it as effectively. Maybe they didn't have a CANS assessor that had hours outside of banker's hours. Maybe they didn't have one that spoke Spanish. It really, and people liked the choice. So it helped with that. Our caregivers, and I will say this is not just telehealth, but this is virtual option in general. It is a convenience for caregivers. Our kinship caregivers often have other children in the home. Taking and transporting children to appointments give transportation and childcare barriers. They may have an appointment where they have to work around the school hours, but if you live in Houston or Dallas or Austin or some other areas, it's almost like you have to push it way out outside of school hours to get to hours where traffic let you get anywhere. So it really was much more convenient for a lot of caregivers. And we found that even when a lot of things kind of dropped way down with the pandemic, our compliance issues we were very consistent and didn't lose any ground with getting the CANS assessment done. One of the things John, it's really not our session, but I will just make a commercial and maybe you'll have me back that I just want to say that we really have enjoyed in our capacity crisis and in the use of CANS, seeing, analyzing those initial CANS. And this is just one slide of an analysis that John and his team did for us, analyzing all of the initial CANs this past fiscal year. Just to have a snapshot, they analyzed children 6 and older and grouped them. And we were able to really see, and I'm just going to say a quick thing about this, the pink, blue, and yellow boxes to the right, those are our children that have really intense needs. They equal about 22% of the children coming into care. And the 78% are in the 4 boxes to the left. We were able to see that children coming into care were coming in with really intense and complex needs. And it has helped us really analyze what services are needed right in the beginning, and to kind of feel better about being overwhelmed with our capacity crisis that is less than 1% of our children, because when 22% are coming in with super high needs and we're able to have them in a placement that meets their needs where they can get their services, it really helped us have a context. So we are mining this and using it quite a bit with our behavioral health stakeholders, with our staff, and our residential providers. And this is just is capturing what I just said. There you go. I wrote it down on a slide. I want to say a couple of things about the whole telehealth concept, and share that we in Texas, and I think we in our country, are a work in process in a pandemic environment. We've learned a whole lot. It's not just telehealth for us. It is, I would expand it and say that child welfare is learning how to use virtual resources, period. One of the things, and I just want to build on this for some of the questions that came up between my presentation and Seth's when we had our question and answers, is the use of court with virtual work, the use of CANS, the use of behavioral health services. I think we would find all in the same basket: the convenience, the availability, but also our families are used to talking on the phone. They're used to working with a FaceTime screen. They are not used to walking in a courtroom. They are intimidated about that. And it's a very scary environment. And many of our families opt not to go. So we're seeing much more increased participation with things like court hearings, just because it's virtual. So we are working with our Medicaid agency and looking at telehealth options all around. In our crisis, as we adjust to other impacts in capacity and have children that are farther away from their community, the behavioral health services, if they were engaged with someone, being able to sustain that relationship, that therapeutic relationship via telehealth has been a real option for us. we found our CANS tools have worked well with this. We find that our families really like it, but just like us, they don't like one or the other. They don't want to all be face-to-face. They don't want to all be telehealth and virtual. They want hybrid. Sometimes it works well, sometimes it doesn't. The going back and forth has really expanded our options, expanded our tools, and given us the opportunity to shift our practice and figure out how to do it. So there you go. That's what's happening in Texas. And Brandon and John, do we do questions before I kick it out west?
So yeah, you can go over some questions. I do want to point out earlier in the conversation, an individual on their iPhone said, personally, I love the Telegraph or telehealth for convenience to the work around my schedule and for travel hours for medical appointments. However, for a majority of the cases with children, a lot of them hate the telehealth work. They hate to show their face, and sometimes they can shut down. Another participant in our Zoom session today said, in my team, I saw an increase in engagement with families. There were months of 100% contact with the whole caseload. Going back to face-to-face, we started seeing a decrease in being able to see them and a lot of excuses for not being home or coming to the office. So some deflection there as a result of the pandemic. This individual works in New York City. So I wanted to point that out. Are there any other questions, concerns, thoughts, ideas for Liz, Liz's content? I certainly would encourage folks to ask the questions that they have. I'm sure that many of you have them. So this is a great opportunity to do so.
Brandon, if I could piggyback on the comments that you shared.
Sure.
I think younger children have a harder time with that. They're really challenged, and so that's a consideration. The computers and the virtual options are used so much with schools because we had to for safety, that you can hear on the news, and as information is learned, the limitations and the consequences of full-time screen work on education, and so it is not something that comes without its drawbacks. One of my favorite vignettes about a youth that illustrates the effectiveness is we had a youth in crisis and had a team of people on a Zoom call talking about options and what we were going to do, and he was present there, and he said, I want to see these people, and got on there, and we saw, his forehead and his eyes as he's looking in. For him, it wasn't so much see me as much as he wanted to see these people who were talking about him, and hearing them was not enough. He wanted to see what was going on with them. So we have a lot to learn, I think, with it.
Absolutely. And I see that Lisa has a question. Before we launch into Lisa's question, I wanted to sort of point out that in the state of New York, one of the things that we sort of saw with regard to children and families and having access to systems of intervention was the idea that there were disparities in connectivity. And so New York State having 63 counties, 19 million people, if you lived in a rural place, you were more likely to not have the connections that you needed based on, simply the fact that your infrastructure might not have been as robust as some of the more urban areas. And so I wanted to sort of point that out and give another layer of context about how this stuff impacted folks differently, even if they're in the same place. Lisa, you had a question.
Yes. I work in Washoe County in Reno, Nevada, and I work for the child welfare system within the county. I'm a clinician that's embedded within the actual child welfare system. And the current program that we have, we do assessments on not all children who come into care, but specific children that come into care that maybe don't already have services set up and might need services. And so when you were talking about utilizing the cans, I'm the only cans trainer in Northern Nevada. And so I'm like trying to get people to buy into it. And when you were talking about your process and you're having like outside stakeholders, I'm just wondering what that looks like. Because as of right now, I'm also the only one who's actually doing cans on our children that are in higher level, like treatment home type places. So I'm just wondering what that looks like for you and how you guys kind of started that process or landed in that process, I guess.
Well, thank you. I think one of our successes was that the local public mental health system was already using a version of the cans, and we partnered with them. So we had a system in Texas that was already using it. We had a big decision to make about whether it was going to be our staff or not staff doing it, and we opted not to do it. And I think that was a good decision. We had to run around the state and you know, I'm a commercial for it. And things like the latent class analysis that was just conducted make people go, oh, that's cool. I want to participate with that. So seeing the benefit of what we can learn from that works really well. We have 14 universities that are part of a 4E contract to have students kind of grow into the child welfare system for employment. And I've told every school in multiple sessions, you want to do something fun in your final semester internship deal, tell them all to become CANS assessors. I mean, it's not expensive. Learn how to do it. We're doing it everywhere in Texas. So even if you know, it might be a way to put a leg up for getting hired to do something, you know, so, and they liked that idea quite a bit. So it's using it. It's just saying we put it in our residential contracts. We're requiring it. So that's helped us quite a bit. And the telehealth really, we struggled with areas where, you know, like we would have wide geographic areas where there was no one. And those were the same areas that didn't have the universities growing it either. They were, if they had one, they could name their time, and it was not widely available. And we had some very experienced, high quality CANS assessors who shared a willingness to do telehealth, and that just really helped quite a bit, open that door.
Excellent. It looks like Wendy also has a question. Wendy.
Hey, I am from your neighboring state of Louisiana, working for one of the managed care companies, and wanted to ask if you guys had any experience. We are also doing telehealth assessments using the CANS. We've had some difficulties in engaging we have to have both the caregiver and the youth present, and sometimes the youth is not wanting to join. We have issues with just kind of video capabilities, right? So we have to do a lot of telephone only assessments. Do you guys have any experience with kind of helping support that youth engagement in some of those CANS assessments? Does that question make sense?
It does make sense. And if the youth doesn't want to talk in front of the caregiver, that is not a barrier for us. We want the CANS assessor to get the information from the caregiver, but it doesn't have to be right then and there where they're talking in front of each other, and there, you know, needs to be the option, especially for older youth, for privacy, if that's what they want to have. So, you know, I think it has given, it's given just greater flexibility with that. It is part of our Medicaid plan. And so clinicians can use other tools that they want to use. They might have their own structured way of assessing every child. And then this is just a tool that needs to be in that toolbox. And having them have the flexibility to do their normal thing in addition to this has also helped. I don't know, Wendy, if that takes care of it. Where you've got my email on there, we can talk about it offline if you need more with that, because you're a neighbor.
Thank you. I appreciate it.
So there's no other questions. I wanted to ask a question. I wanted to first, Liz, give you a shout out for, I think, reminding us something that's really important. So you said something early in your talk about the people who do this work. And I think we can't highlight enough that although we have lots of problems and there's lots of things that we need to fix, there's also a pretty amazing group of human beings who have committed their lives to, for very little pay, to try and help people and to help children and families. And I think always remembering that is important. So thank you for making that mention, because I think that's a big piece of how we generate change and recognizing the strengths we have in our system. I do have a more difficult question, however, because so 95% of the adult population in Brazil is vaccinated. Almost 90% of the adult population in Canada is vaccinated, and the expectation is in the next few weeks, it'll be up to that level or higher. So the United States is one of the very few countries where there's a significant and vocal part of the community that is hesitant to embark in that. And so I think Texas is fairly famous for being the home of some of those individuals. And so I'm wondering if that reality influences how you're approaching telehealth and the management of the system and those kinds of things.
Well, I'll just say that we are a part of state government, and it is unfortunate to see when the pandemic, and whether vaccinating or not, masks or not, all of that stuff is very politicized. I think that's difficult for us. But what I try and do, what my team is very focused on doing is we have a job, and these children have to be protected. And so we have confines that working in state government, there are always limits on what we can't do. And we work within those.
Sense.
I just tell everyone I'm vaccinated.
We're not allowed to ask that at the University of Kentucky. So I do what you do, and I say I'm vaccinated. So
we can't ask either. And we're also, there are different requirements about, you need to have at least a hybrid public meeting, and the courts will decide what happens with, can you have a mask mandate or not in Texas. But so I just do social work and child welfare the way that I always have for 40 years, and that's a big fat golden rule. I wear a mask. I got vaccinated. I'm going to work with you whether you have either of those things, because I'm going to help other people. That's what I do. And that's how I want people to treat me, not.
That's great. So you just stay away from the whole politics of it and just stay out of it.
What else can you do? I still want to keep working.
Right. One last thing, I was struck, and I hadn't even thought about it, so I thank you, about the court observation. The fact that this is so much more efficient for everybody. So I'm wondering, do the judges like it or not? Because that, of course, decides whether the stuff that's done in court stays the way it is or changes back.
In Texas, we have a Supreme Court Children's Commission that's leading the charge with this. We have what we call child protection courts throughout the state. These are in not your super urban areas where maybe one county didn't have enough for a full docket of child welfare cases, so they have kind of a catchment area. And they were already equipped with computers. They were already equipped with video equipment. And it was very easy to work with them. We had feedback from parents and from relatives who were comfortable showing up when they weren't before. Our caseworkers don't have to pay for incredible parking and travel and sit all day in the hall waiting for a hearing. So it had so many efficiencies, it seemed a no-brainer.
Mhm.
But we do have the questions from the courts about due process and evidence and, you know, that kind of stuff. And so what we're doing in our state is that there are several courts who are doing a formal study about how can we best do this in a hybrid way so that people have the option, so that if they can't come in person, that doesn't mean court doesn't happen, or if they don't have the ability to do it virtually, it doesn't, they're, you know, excluded. And we'll see how those results turn out.
Yeah, and I can
Maybe
answer
more
for
positives than negatives.
For San Diego, we're in a similar situation. So basically the first 3 months, we had no court hearings, no criminal court hearings, no juvenile court hearings, which was a huge impact, right? So then in July, we got up and running with the virtual courts, and we have never returned. Our clients can come to the office with an appointment since COVID decreased, but now that the Delta variant, we didn't return to having court hearings yet in person, or to even having child and family team meetings, conversations with our CANs in person yet. So yeah, it's been a good adjustment, and we had the same experience as Liz in Texas. Families greatly prefer the virtual court, especially caregivers, for the same reason that Liz mentioned. They have multiple children, they have multiple needs, so it's such a convenience.
I think you just introduced yourself.
Hi.
Let's go west.
Go to the coast. I hear it's paradise, but